So much to discuss. The Delta variant, vaccines, children. Let's bring in Professor Barry Schoub. He is the chair of the Ministerial Advisory Committee on Vaccines. Professor, always good to have you on the program. Welcome.
Good morning, Blaine. Thank you for having me.
All right,
good to be here.
It's always a pleasure because we need to understand the trajectory of this virus. I want to talk about the latest case numbers that we have. And in terms of the 7-day moving average numbers of new cases, according to the NICD, the total number of cases yesterday is lower than the previous day, but higher than the average number of new cases per day over the 7 preceding days. Break that down for us, Professor. What does that tell you?
Yeah, Blaine, I think the reason why we use a 7-day moving average, in fact, in some cases, even a 14-day moving average, because these figures really depend on what is being reported. And obviously, there are fluctuations. It fluctuates not only the number of cases, but which cases are being reported. Now, sometimes a case may be 2 or 3 days before it gets reported. And this is why, to be really meaningful, you need to have a 7-day average, at least a 7-day average. And this is why, for example, when the curves are drawn, they're drawn on the base of a 7-day, we call it a 7-day moving average, because obviously it moves, day by day, but over a 7-day period. Yeah. So we take that average over that 7-day for each daily case.
I want to talk about vaccine doses administered, and I want to look specifically at the percentage of doses administered by age group and sex. And we have a graphic up. I'll ask my technical director, Michael, to put it up for you so the viewers can see what we're talking about here. And this shows in yellow, female, and male green. So if we look at the 60 plus, 31% female, 19% male. 50 to 59, 11%, over 11% female, 8% male. 35 to 49, 14%, over 14% female, over 10% male. And then the 18 and 34 group, 2%, over 2% female, and just over 1% male. Why are more women getting vaccinated than men?
Gosh, Brian, I wish we knew the reason for that. We don't really know. And in fact, I must say, I haven't really heard of this in other parts of the world. I wonder if we are unique in that respect. Look, I think we can speculate. Could it be that maybe females are more used to having a contact with the healthcare system from being pregnant and so on? That may be a reason. Look, we're really guessing. But it is worrying because, it's a 60-40 female to male ratio, and particularly worrying in the 60 plus age group, which is really the kind of main target group that we're really worrying about. So we need to address this. Why, in fact, are males relatively more reluctant to get vaccinated? This is really a kind of key point that has to be addressed.
Right. Let's just talk a bit about that and maybe just satisfy some of the questions that many have with regards to vaccine protection. Help us understand this. When you look at how the vaccine actually works, I was listening to one Dr. Sanjay Gupta the other day explaining that the antibodies, specifically IgG, and you can explain to the viewer what IgG is, works more so at the level of the lung. So it's basically trying to keep this virus from getting into your lungs where it causes severe disease, illness, hospitalization, and death. It doesn't work as well in the upper airways. So you can still be carrying the virus in the upper airways and test positive after being vaccinated, correct?
That is correct. You must remember, these vaccines are given what we call systemically. In other words, they're given in the arm and that get into the bloodstream. There is another part of the immune system called the mucosal, or the surface or superficial immunity. That's where the virus gets into the body. Ideally, we'd like to have an immune protection at the mucosal surface, because we want to really prevent the virus getting into the body. And also, if it does get into the body, we want to prevent it multiplying and being excreted from that mucosal surface, because that's how the virus gets into the community. Unfortunately, we've got our first generation of vaccines now, which are very good. They're excellent. And they've been very good in reducing the severe infections. Not quite as good in reducing the milder infections, mainly probably predominantly because they don't cause that effective mucosal immunity. So the virus still gets into the body, it multiplies, causing mild illness. The systemic part, in other words, where it's in the bloodstream, will prevent it getting into the lungs and causing the more severe disease. Ideally, hopefully, the next generation of vaccines will produce good mucosal immunity. Because the problem where we are now with our first generation of vaccines is, yes, it does limit the more severe, which is great, not quite so good the mild infections, but importantly, it also doesn't quite guarantee protection against onward transmission of the virus. So people get mild infection too. About a third of people that are vaccinated will get a mild infection if they are infected. And also, they will also, to some extent, also transmit infections. Right. It is reduced by the vaccine. I must say, in the vaccines, but not enough. And therefore, there is still ongoing transmission and ongoing mild infections.
Right.
And people need to kind of have these expectations of the vaccines. They're good for the high-end protection, not quite as good for the low-end protection.
So some people who have vaccinated, they then test positive and say, look, these vaccines are useless. It's not working. That's not the case, right?
Yeah. That's not the case. First of all, mild infections themselves are reduced. I must emphasize that. I don't want to kind of give the wrong impression to listeners. It is reduced, but not quite as much as we really would expect. Onward transmission is reduced, again, not ideally. And this is why if you've had your vaccine, we still say you must take all the precaution. Must still wear masks, must avoid social gatherings, must sanitize hands and so on, because unfortunately the vaccines are not 100% perfect.
Professor, explain the importance of why someone who has already had COVID-19 to get vaccinated despite having the antibodies. Talk to us about the issues around reinfection.
Yeah, this is the kind of a slightly odd thing about COVID. If I can just take a step back, with the other infectious diseases, if you take like measles, for example, if you get measles, the natural infection, you actually get a much better immunity than the vaccine. And this actually holds for most of the things that we got vaccines for, most of the infections we got vaccines for. The natural infection gives you a better immunity. COVID is the reverse. COVID, the natural immunity gives you good immunity, but certainly not as good as the vaccines. And there's a good reason for that, because the way that the vaccines are designed, they are designed, the actual part of the vaccine which stimulates the immune system it's stabilized, and because it's stabilized, gives a much more powerful immune kick than the natural infection. So to summarize, the vaccine is actually a better stimulator of the immune response than the natural infection. And that's why we say people that have had COVID should still get vaccinated. They'll then get an excellent immune response, because the initial infection, the natural infection, will act as a primer. In other words, it'll educate their immune system. Yeah. Then when they get the vaccine, that'll boost the immune system, and they'll get a very good immune response. So yes, they should still get vaccinated, even if they've had COVID for that reason.
Prof, what do you say to people who have raised the issues of, well, we don't really know what this vaccine contains, how it affects the body? Operation Warp Speed, it has been one of the fastest vaccines developed, in decades. Questioning the efficacy of the vaccine. How would you break it down to the layman in terms of having confidence in these vaccines?
Yeah, look, these are very justifiable questions. They're very understandable questions. People do raise the concern that the vaccines have been developed, as you say, at warp speed, as the Americans have coined that term, at warp speed. Look, I think this is really a kind of reflection of how sophisticated, how developed our science of understanding and developing vaccines has become. In 2021, where we are at the moment, we are really got a tremendously in-depth understanding of vaccines, the immune response, the development of vaccines. And I think that we have been able to develop these vaccines so quickly is really because of that. And at the same time, because we've got such a sophisticated science, it also guarantees the safety of these vaccines. Because as developed as the science was, as advanced as the science was to develop these vaccines, so advanced is the science to guarantee our safety. And the safety requirements, the safety at the regulatory body is far more sophisticated, is far more intense and rigorous and thorough than in previous vaccines. So in fact, the safety of these vaccines is more guaranteed than previous vaccines. So I think it's two consequences of our science. Being able to have these vaccines at a crisis and being able to kind of really effectively, where the vaccines have been rolled out, to reduce the toll that this infection has caused. Yeah. And at the same time, that those vaccines have been so rigorously and thoroughly examined for their safety. So I think we can reassure the public, and there have been many, many studies over the millions of vaccines that have been developed to ensure that they are extremely safe. The side effects are mild if they do occur, and the serious side effects are extremely uncommon. They're about 1 or 2 or 3 per million doses.
Professor, reportedly, 4 countries in Africa have entered their 4th wave of surging COVID-19 infections. Looking at the case numbers here in South Africa, the trajectory, the trends, is a 4th wave in South Africa a foregone conclusion, or can we prevent it?
Mm-hmm. No, I think it is a foregone conclusion. You know, if we look at the periodicity, there's a couple of months between the waves, and I think we can expect probably towards the end of November, beginning of December, going into the Christmas season, that we will have a 4th wave. What we don't know is this: is it going to be due to a new variant? Is it going to be, how severe is it going to be? I think those characteristics we don't know. That's unpredictable. I think what we can be reasonably certain that we will have a 4th wave. Hopefully it'll be much milder than what we've experienced up to now, if it's not going to be due to some new unpredictable variant that we don't know its personality. So yes, I think it's a foregone conclusion. Hopefully not as severe as unfortunately, each of our 1st, 2nd, and 3rd waves has become progressively more severe, because each of them has been due to the 2nd and 3rd variant, due to 2nd and 3rd wave due to new variants. Whether the 4th wave will due to a new variant, that we really don't know.
Well, let's just talk about these variants and various variants of concern. Delta. We were initially told that the virus causes a mild illness in children, though some children have become pretty sick. But has things changed with the highly contagious Delta variant? Are children getting more sick because of this variant?
I think yes. I think this has been a universal throughout the world observation, that with the Delta variant, certainly the age is certainly come, up to now, let me take a step back. Up to now, really, children have tolerated extremely well. Not only children, even adolescents and even young adults have tolerated the infection very well, and it's mainly hit the elderly. Now we've had our vaccine being rolled out, and first of all, obviously, it's mainly the elderly and the older people progressively going downwards who've been vaccinated and been protected, and the younger folk have not been. So that's the one reason. The other reason is that the Delta is a much more contagious, much more infectious virus, and therefore it spreads and penetrates to a much greater extent in the population, including the younger folk who weren't so affected previously. So it's also an expression of the greater contagiousness of this variant. And then thirdly, it does appear to be also now affecting younger people more severely than the previous variants. So I think there are really 3 reasons: the vaccine the vaccine coverage, the virus contagiousness, and also intrinsically that this virus does appear to affect younger people more.
Right.
But still, the very young are probably not that seriously affected.
Right. And are doctors seeing any change in the clinical presentation with the Delta variant? Have symptoms changed in any way?
This is very difficult to assess at this stage. There have been some reports that the symptom spectrum has changed to some extent. In other words, it seemed to be more like the flu-like illness. The respiratory symptoms seem to be more prominent now. Previously, it was more like the fever and the generalized expression, the muscle aches and pains and so on, and those that get it mildly. In terms of the severe disease, I think that hasn't changed at all. So I think it's really in the spectrum of the milder illnesses where there has been some reports that there may be a shift in how it's expressing itself. I don't think one can put too much by that.
Yeah.
I think we still have to rely on being tested to kind of establish whether somebody is infected or not.
And what about vaccines for those younger than 18, primary school children, etc.? How far are we from that? Look, I've got my vaccine. I can take that risk, calculated risk. But when it comes to my child, and I'm sure all the parents will be like that, I need to be 100% sure this is safe for them. How far are we from that?
Yeah, at the moment, the vaccine in this country is only licensed for adults from 18 years of age upwards. So it's actually not licensed for children under the age of, or adolescents under the age of 18. This may change, but I think our first main aim is really to get coverage in the adult population. We need to focus on that because we are way behind. We've still got quite a large gap to kind of fill up before we can kind of contemplate looking at younger age groups.
You break it down so well, Professor. We thank you very much indeed. Clarity is indeed needed in order to break certain, vaccine hesitancy going forward. The more facts we have, put it out there, the better people can take it on and make decisions for themselves as well as their families. We thank you very much indeed, sir, for your time. Be well.
Thank you, Blake.